So thank you for including this talk to today's session. It's been exciting to hear about revolutionary changes in CLL therapy. The transplant is one of the modalities. I think we have to keep it in our equation. And what I want to do today is to just give you an overview of transplant studies and present you a few results. So to talk about role of transplant in CLL, we have to really put it in evolving perspective of the past 20 years. As a high-dose chemotherapy was tried for CLL with the rationale to eliminate the leukemic clone, it was tested in multiple prospective studies, and as we all know, it did not work. The progression-free survival was improved. However, there was no advantage for overall survival, and really comparing to FCR nowadays, these patients have about the same outcomes as with a modern chemoimmunotherapy. The late events were a problem, and so nowadays there is really no current role for autotransplant, at least in Northern America. With the use of a myeloablation, the allogeneic donor transplantation has evolved, and initially it became obvious then that relapses are lower after allogeneic transplant, and the GVL effect protects from relapse. However, the myeloablation was poorly tolerated in CLL patients associated with a very high transplant mortality, and of course this wasn't a treatment for patients with CLL who are elderly and often have comorbidities. The major discovery in transplant world was a realization that the engraftment and the subsequent GVL effect can be also observed without the use of myeloablation, and that led to the development of reduced intensity conditioning, where the therapy is non-ablative, and this is a safer platform allowing to treat patients with a higher age and with poorer health. The CLL cells, which are resistant to chemotherapy, retain the sensitivity to immune-mediated eradication. And the allogeneic transplant is therefore associated with very potent graft-versus leukemia activity. So what's the evidence for that? There is a multiple lines of evidence, and I just put the incidence of remission and attaining of flow cytometry negative state and by flow and cytogenetic in this paper from Fred Hatch, where the increasing time for transplant led to improved MRD negative status, suggesting that MRD can be eliminated over time. In multiple series, the chronic graft-versus disease was associated with a protective effect on relapse. And then efficacy of a donor lymphocyte infusion was demonstrated by multiple studies where the DLI are effective for patients with relapse and with a persistent MRD state after transplant. One of the hallmarks of the RIC is improved tolerability, and I pulled several recent studies. So I really focused on the studies which were published in the last 5 to 7 years and looked at the toxicities which were reported. It is obvious that the mucositis and infections have been decreased, and especially this result in a very low death rates in the first 100 days, which were single digits. However, the non-relapse mortality remained elevated in about 20%, so this is half of what we see with the myeloablative PrEPs. 20% of patients have a non-relapse mortality, mostly attributed to higher grades of acute and chronic graft-versus disease. There is no really improvement in the GVH incidence or treatment over the past 20 years, and this remains a major challenge of transplant. About 20% of patients will have a high-grade GVHD, which it can be often fatal. So the transplant outcomes improved over the past decade, and as this study shows from Dana-Farber, comparing the cohort of patients before and after 2004, there is a marked improvement in survival, and mostly as a result of improving supportive care, better antifungal therapy, better antiviral therapy, preemptive treatment for CMV, and this is significant and also shown in other studies more recently. The mortality is not that different by age group, and really, although there is some difference, the 60 and 70 years old patients probably do about the same, and the age is not significant as opposed to really the fitness of the patient and presence of the comorbidities. So what are the indications of allotransplant which are currently accepted? This is being developed by the consensus from the European BMT registry group and were published in 2008 and really are widely applied in Europe, North America, and worldwide. The patients with a high-risk CLL who are previously treated and lack a response or have an early relapse after purine analog-containing therapy, the patients who relapse within 2 years after purine analog combination, and then patients who have a p53 deletion mutation by and require therapy. So this is a table detailing the outcomes of some of the important and largest studies for CLL, which really included these high-risk patients. The median age of these studies is about high 50s, so it's about 10 years older patients than we used to see with the more intensive regimens. Most of these patients have seen fludarabine, and many are with 17p deletion. The conditioning is all these studies are with a reduced intensity conditioning, and some of them have fairly long follow-up over 5 years. The relapse rate varies quite a lot and really is a reflection of heterogeneity of patients who are put on these studies and selection of the patients. It varies anywhere from 20 up to 30% relapse rate. However, what we see from these studies is that the progression-free survival plateaus between 40 and 50% at 5 years. And up to 50 to 70% of these patients are alive. How about the efficacy of allograft for patients with a 17p deletion? Many of the studies I showed you did include these patients, but the numbers are really small. This is probably the largest and still very small study which is focused on this patient group. The patients were enrolled after demonstration of the p53 either by FISH or cytogenetics, and I think most of these patients had fludarabine treatment. The FISH analysis was done, and the median FISH percentage was 70% of cells, so this is a really high level of involvement by 17p. 53% of these patients were in remission, and as we see here, there is about 34% of patients were disease-free at pretty long survival, 9 years, and there is a plateau in this curve. So the main questions for transplanters, of course, and for all of us is, who should be transplanted, when, and how we should transplant these patients. For transplanters, there is one other important question, and that is who should not be transplanted and who is not going to benefit from transplant. So these studies can help us to look at this population of patients. In this right panel, the two groups are compared, the patients with the bulky lymph nodes versus the patients without a bulky adenopathy. And as you see, the bulky patients really are having a high risk of relapse and poor outcomes. This is a study done by Dr. Brown here from Dana-Farber, looking at or trying to identify the prognostic score for patients with CLL. And as they demonstrated, the patients who have a progressive disease or stable disease at time of transplant, high lymphocyte count, high LDH, which really is all reflection of a very active and high bulk disease, are doing poorly, and they really don't benefit from this modality. These are some other studies demonstrating various prognostic factors, and what I wanted to point out is here that the cytogenetic groups do about the same. So it appears that the transplant have a potential to overcome adverse features seen with these adverse cytogenetic patient populations. This is important for transplanters, and that is that the choice of donor no longer should be a barrier to an allogeneic transplant for patients who have indications, because the unrelated donors do about the same as sibling donors. In fact, in one of these series from Seattle, the outcomes for the progression-free survival was actually better with the unrelated donors compared to siblings, although the number of patients is small. So the table summarizes here the prognostic factors for progression-free survival in these different studies. And the message here that the two main important factors are comorbidity score and perhaps high age. However, the number of prior therapies, refractoriness to purine analogs, 17p deletion, is really not prognostic for outcomes for allogeneic transplantation. However, being refractory or having a high bulk of disease at the time of transplantation is highly adverse. So what's the current state of transplant for CLL? I think it's very controversial, and the landscape is changing rapidly in a non-transplant world, not as rapidly in a transplant world as we wish. But I think that needless to say, most patients with CLL will never need transplantation. However, for those with very high-risk features, the transplant should be considered prior to developing the refractory disease and prior to transformation to high-grade lymphoma. This is indeed the only curative therapy for the selected patients with high-risk CLL, and these are the patients who have a good performance status, have less than 2 comorbidities, and the most protocols enroll patients up to age of 70, and age probably should not be anymore the barrier to transplantation. The EBMT indications remain valid. However, the timing of a transplant, I think, is a moving target, and especially in the landscape of new therapies for 17p deletion, it may not be in the best interest to transplant these patients in a first remission, because you do have an agent which can bring the patients to the second remission in case of relapse after the primary therapy. So there is a prospective CTN trial going on in North America. This is being developed, I think, 3 or 4 years ago. It used reduced intensity conditioning for all patients, regardless of age. There is really no role of ablative conditioning for CLL anymore. It has 2 cohorts: early cohort, where the patients are in a first remission, and then late cohort for those who are refractory. And all patients are expected to have some sort of therapy, of course, prior to transplant. They're using fludarabine-based conditioning, and this particular transplant protocol includes rituximab in a peri-transplant time and then post-transplant in attempt to control the disease, but mostly to also help with the GVHD. So what are the future of transplant for CLL? I think we need to develop safer platforms to deliver T-cell versus leukemia effect. This is really a first precedence for immune-based therapy for CLL. And it's a great concept which can be applied in a different settings, such as CAR therapy. I think there is a potential opportunity to combine novel immunotherapeutics pre- and post-transplant, which can lead to higher cure rates. The new drugs can be used by reducing tumor load pre-transplant. So, in fact, it may allow a higher proportion of patients to be transplant eligible, to be a better candidates because of the less morbidity due to relative safety and well tolerance of these therapies, but also the disease is likely to be much better controlled. The indications and timing will likely evolve. This is a dynamic field, and I think that this talk will be very different 10 years from now. And I think we have many options for relapse patients with the novel target therapies, but the duration of these responses are currently unknown, and therefore the transplant definitely should be considered for all younger patients who fulfill the criteria, as I mentioned before. Thank you.